Just type yes in the chat box if you can all see my screen now. I hope you all can see my screen now. And today we are here for the 64th Page Journal Club. And I'm just going to start the meeting now. Just a moment while I just make it full screen. Okay, so welcome all of you to the 64th Pain Journal Club from the Mumbai Pain School. And today we are going to discuss MSK Ultrasound Basic, and we have got some exciting topics and some exciting discussion coming up now. So before we begin, as always, pain medicine world over has got a lot of diverse issues with variable standards, different learning requirements, and different offerings. Money and time, of course, is something which prevents us from our pain physicians from learning. And this is to overcome this. We have started Mumbai Pain as an initiative of Maitri Shah Spine Wellness and Pain Relief Center with a lot of online outreach at various social media channels. And of course, online learning and on-demand videos are what we do, but we have both free and paid content. Most of our content is free of cost, and we do a lot of hands-on workshops. The next one is in December 9 and 10 in Mumbai. We are fortunate to have expert faculties from all over the world. And it's said that the best teachers, they teach from the heart and not from the book. It's difficult to teach as well. But what's a journal club? It's just a club, only difference being that we are going to critically evaluate the recent academic literature, which is based on a predefined subject. And attendee participation is very important. We have got a lot of you on live channels as well as some of you on the Zoom. So please come up with your comments, suggestions, questions. All are welcome. It's tough to be regular, so try to be regular, and every Friday we'll mostly meet you at 8 p.m. Even Harrison had his own journal club wherein he used to critically evaluate his academic literature twice a month. And of course, time and discipline is very important. So I request the speakers to stick to their timelines. Healthy skepticism or praise is most welcome. This is a bit about me. I work and practice in Mumbai. But today we have with us our faculty, who is Dr. Sanjog Mekewar. He's a consultant spine and pain physician at multiple hospitals in Pune. He's also visiting consultant at Sassoon Hospital, Pune, and he's a director of Jeevisha Pain Management Center at Pune. His area of interest is region med and spine endoscopy, and he's got multiple publications. He's a avid traveler and explorer. So welcome, Dr. Sanjog. Welcome to the Journal Club. Over to you, Dr. Sasmit, who is going to present the first paper. Dr. Sasmit, if you put up your slide, I can just read out your intro. After that, you can start. Okay, I think I need to make you the host. So now I think you can share. Just try now. And you should be able to share. Yeah, please. Okay.
Can you see my slide?
Yes, I can see your slides. Can you put on your CV?
Yes, sir.
Yeah, you can make it full screen. Yep. So those of you who joined late, this is the 64th Pain Journal Club, and we're going to discuss today MSK ultrasound. And the first paper will be presented by Dr. Sasmit Lotliker, who is MD and FIPM from Patil University in Navi, Mumbai, and he's a consultant interventional spine and pain physician at Manipal Hospital, Borkar Hospital, Menzies Hospital, multiple hospitals in Goa, and also the director of Thavasmi Spine and Pain Clinic in Goa. So over to you, Dr. Sasmit.
Good evening, everyone. Thank you, sir, for introducing me. So my topic for today is musculoskeletal ultrasound basics. So basically, this is a review article which was published in the Cleveland Clinic Journal of Medicine, having an impact factor of 6.5 in April 2018 by Dr. Michael C. Forney and Dr. Patricia B. Delzel. in the Department of Diagnostic Radiology and Orthopedic Surgery at Cleveland Clinic. So this is the departmental affiliation. Coming to the introduction, so ultrasonography has been emerging as a core method to evaluate musculoskeletal problems. It has best been used for imaging superficial structures which are limited only to one quadrant of a joint. There are several advantages over over other imaging methods. This includes lower cost, ability to perform dynamic examinations, higher spatial resolution of superficial structures, better patient comfort, and essentially there are no contraindications to ultrasound. Also, MSK ultrasound was first utilized in 1970 for investigating rotator cuff injuries, but later on it had a plateau phase because of the advent of MRI. In the recent times, we have seen that MSK ultrasound has again shown a resurgence as a specialized service for the diagnosis and treatment of various MSK conditions. Besides radiologists, it is also been performed by physician groups with specialized training, which includes sports medicine physicians, rheumatologists, physiatrists, neurologists, and orthopedic surgeons. Coming to the aims and objectives of this article, it is to review the basic physics which is underlying the ultrasonography, its advantages and disadvantages as compared with other imaging methods, and its common clinical applications. So the main part, coming to the clinical implications. First, let us see what are the ultrasound mechanics. So ultrasonography basically uses high frequency sound waves to generate images. The transducer probe emits sounds from many piezoelectric elements at its surface, and the sound waves travel through and react with tissues. So if you see in this is the transducer, and these are the piezoelectric crystals which you can see over here. This is the arrangement of the piezoelectric crystals. So electric current will be generated from the ultrasound machine. It goes and hits the piezoelectric crystals, and it causes vibration of these piezoelectric crystals. This will generate ultrasound waves. These ultrasound waves are again reflected back, hit the piezoelectric crystals, and then again this is gone to the ultrasound machine, which then forms the image. So the sound reflected by the tissues is then detected by the transducer and converted to the image. Objects which reflect sound appear hyperechoic, that is brighter, whereas tissues which reflect little or no sound, they appear hypoechoic or darker. So if you see in this image, this is a lipoma or a stone. So this will reflect most of the sound, so it appears hyperechoic or brighter, whereas cysts, gallbladders, and vessels, etc., will appear hypoechoic or anechoic because they reflect little or no sounds. Coming to high resolution imaging of superficial structures. So ultrasound basically follows a fundamental trade-off between image resolution and the imaging depth. Higher frequency sound waves, they do not penetrate far enough into the tissues, but they definitely generate a higher resolution image. Lower frequency sound waves on the other side can penetrate further, but they yield lower resolution image. Although high resolution imaging of deeper structures with ultrasound is not possible, many musculoskeletal structures are located superficially and hence are amenable for ultrasonographic evaluations. So if we see this image here, the first image, image A, shows a superficial patellar tendon, and using a high frequency probe, if you can see, the clarity is very good. So higher resolution and with a higher frequency probe, but the depth is very less. Coming to deeper structures like the iliopsoas tendon, the lower frequency probe is used, which can penetrate into the deeper structures, but as we can see, the resolution is very poor. Coming to artifacts. So what are artifacts? Low attenuation of certain materials like simple fluid results in artifacts on ultrasound, making the tissues behind the fluid appear brighter than the neighboring tissues. These artifacts may be reported as increased through transmission or posterior acoustic enhancement. So if you can see in this image, this is a low attenuation object, and behind the low attenuation object, there is an enhancement artifact which we see. So it is the posterior acoustic enhancement. Metal, bone, and stone can reflect all the sound waves which reach them and render any structure beyond them as invisible. This is known as shadowing. So this forms a problem for imaging of structures in or near the bone or stone. So if you see in this image, there is a gallstone over here, and it is a highly reflective object. So all the sound waves which reaches the gallstone are reflected back, and as a result, there will be shadowing artifact which is seen. So there is nothing which we can see beyond this stone. Subcutaneous fat can also attenuate the sound waves, which limits the use of ultrasound for obese people. Coming to anisotropy, so artifacts due to the direction of transducer are known as the anisotropy. Anisotropy will cause highly ordered tissues like tendons and ligaments to sometimes appear hypoechoic, which is also the appearance of diseased or disrupted tendons and ligaments. So this can be minimized when the transducer is held perpendicularly to the structure of interest. So if you can see here, this is the image of a supraspinatus tendon. In figure A, we can see that the position of the probe is not proper, and as a result, we can see that there is a hypoechoic defect which is seen of the supraspinatus tendon fibers. Now, once we have corrected the position of the probe and the probe is held perpendicular to the supraspinatus tendon, the anisotropy disappears, and as a result, we can see the tendon in a proper structure. So high frequency linear transducers, they reduce the anisotropy as the flat surface keeps sound waves more uniformly perpendicular to the structure of interest. Now this has allowed for imaging of superficial structures more superior than the MRI, and it offers more than twice the spatial resolution of a typical 1.5 Tesla MRI examination of superficial structures. Coming to operator experience, a solid understanding of musculoskeletal anatomy is very imperative. Probe images only a thin section of the tissue about the thickness of a credit card. Referencing adjacent structures for orientation is more difficult with ultrasound as compared to CT or MRI. Accuracy of the ultrasound is highly dependent on acquiring as well as interpreting the imaging of the structures, unlike an MRI, which is more dependent primarily on image interpretation only. And interpreting physicians also must check that the sonographers can capture only the main targets. Coming to the strengths of the musculoskeletal ultrasound, there is no ionizing radiation exposure in ultrasound. Also, unlike a CT or MRI, ultrasonography equipment is portable. There is also increased patient comfort. That is, patient positioning is much more flexible as compared to CT or MRI. And also, there are very less incidences or no incidences of claustrophobia. Higher resolution imaging is also done for superficial soft tissues. A real-time dynamic examination can also be performed with ultrasonography, which increases sensitivity, unlike in CT or MRI. And this can safely be used even when there is implanted hardware, like any pacemakers. Coming to the weaknesses, sometimes there can be limited field of vision, which is inappropriate for the survey examination, like for ankle, knee, or hip pain. Unlike a CT or MRI, it does not provide a bird's eye view and important abnormalities which can be missed while evaluating larger areas. It cannot evaluate bone or intra-articular structures like cartilage, bone marrow, labrum, and intra-articular ligaments, for which MRI is the gold standard. Sometimes sometimes the ultrasonographic evaluation can be very time consuming, especially if you're having a detailed evaluation, and can take up to 1.5 to 2 hours for scanning as well as the evaluation. So if you can see here, this is the MSK ultrasound, which is inappropriate for evaluating large areas. Coming to current clinical indications, first is fluid collection. So ultrasonography can help in evaluating small fluid collections in the soft tissues, although it is non-specific, and results must be correlated with the clinical picture to narrow the differential diagnosis. Now, these fluid collections can either be loculated or non-loculated fluid collections. Coming to non-loculated fluid collections, this involves more fluid than is simply interspersed between the tissues. It has no wall or defined margins. This can either be simple or complex in appearance. A simple fluid is usually appearing anechoic, whereas a complex fluid appears more heterogeneous and may contain some septations or debris. Subcutaneous edema, like seen in post-op or trauma cases, venous insufficiency, inflammations, infectious processes, appear as non-loculated fluid which is interspersed between the subcutaneous fat lobules. Now here, if you can see, this is the non-loculated fluid collection which is seen on the ultrasound abdomen, showing the CSF ascites, which is present between the abdominal wall and the mesentery. Coming to loculated fluid, these have got well-defined margins or discrete wall which does not follow the normal tissue planes. Now, this can again be simple or complex, and this is usually seen in hematoma, abscess, ganglion, or less commonly neoplasm, which can mimic a loculated fluid collection. So, it is the ultrasound image which is showing the loculated fluid collection having the septations. Now, ganglion is a specific type of a well-defined anechoic loculated fluid collection which contains synovial fluid arising from a joint or a tendon sheath. Most commonly, it appears at the wrist, most often arising from the dorsal scapholunate ligament and the volar wrist between the radial artery and the flexor carpi radialis. So if you can see here in this image, this is the ganglion which appears as an anechoic loculated fluid collection. Coming to power Doppler. Now power Doppler is very important because it can detect increased blood flow which surrounds the fluid, and it determines the likelihood of any acute inflammation or infectious cause. Coming to joint effusion and synovitis, so ultrasound has been highly sensitive and specific for synovitis, even much more superior than CECT. Joint effusions appear as distended joint capsule which contain either hypoechoic, that is complex, or anechoic or simple joint fluid. Now, a complex joint fluid may again contain debris and occurs with hemarthrosis, infection, and inflammation. Power Doppler can distinguish this synovitis from joint fluid because a power Doppler can show an increased blood flow, which is a feature of synovitis. Also, it helps in monitoring the synovitis therapy. So, in cases of subclinical synovitis and enthesitis, ultrasound may be used to predict the further disease as well as disease flare-ups. Coming to soft tissue masses, this helps to evaluate the soft tissue masses no larger than 5 centimeters in diameter and no deeper than the superficial muscular fascia. It is, however, less reliable for showing the margins of the mass and its relation to the adjacent structure, especially if the mass is much more deeper or larger in size. Soft tissue masses are accurately diagnosed with ultrasound include lipomas, ganglion cysts, foreign bodies, and simple fluid collections. Nerve sheath tumors can also be diagnosed with ultrasonography. Coming to certain ultrasonographic features of certain soft tissues, first is the tendon. So a normal tendon appears as hyperechoic, compact internal fibular pattern. Anisotropy may be present which mimics tendinosis or tendon tearing. Tendinosis will be seen as hypoechoic, focal or diffuse, abnormally thickened, loss of compact fibrillary structure, and possibly regions of fiber disruption. A tear can either be partial or full thickness tear, while tenosynovitis will be seen as a thickened tendon sheath or peritendon with increased fluid. So we can see the images here. This is the normal Achilles tendon, in which we can see the compact arrangement of the fibrillary pattern. This is the tear of the Achilles tendon. Here we have the tendinosis, where it appears hypoechoic as compared to the normal tendon, and also there is loss of the compact fibrillar pattern. This is a picture of tenosynovitis. So in tenosynovitis, basically there will be enlargement of the peritendon, as well as there will be fluid collection, which is usually detected on power Doppler. So this is the power Doppler signal which shows the fluid collection. Coming to ligaments, a normal ligament will appear as hyperechoic with compact morphology, but it has less ordered fibrillar pattern as compared to the tendon. Low-grade ligament injury can either be normal or thickened, but it will be hypoechoic. Intermediate or high-grade ligament injury will be seen as fiber disruption with surrounding hematoma or fluid collection. So this is the normal ligament which is seen here, and this is the ligament injury which is seen as hypoechoic structure. Coming to muscles and nerve, so normal muscle is mostly hypoechoic with interspersed hyperechoic lines and dots representing the perimysium and the epimysium. A normal nerve is less compact. It appears more varied shape than tendon and ligament. It also has semi-compact bundle of hypoechoic nerve fascicles which is surrounded by the hyperechoic tissue. Neuritis may be seen as abnormal nerve enlargement with fascicular swelling, blurring of the interstitium, perineural thickening with possible scarring in entrapment cases. So if you see here, this is the normal muscle. So here we have the hypoechoic structure with interspersed hyperechoic lines and dots which represent the perimysium and epimysium. This is the normal nerve again which has got the hypoechoic structure surrounded by hyperechoic structures. Whereas this is the case of neuritis which is showing the thickening and the enlargement of the nerves with associated swelling. To conclude, there is no single imaging method which can yield all musculoskeletal diagnosis. Like any imaging technique, ultrasound has its own strengths and weaknesses, which is more specific to orthopedics. X-ray, CT, and MRI, all of them play an important role in investigating musculoskeletal problems and are complementary to each other and also to ultrasound. So the take-home message is that the role of ultrasound in diagnosing various musculoskeletal problems and effectively performing the various MSK interventions has been increasing rapidly. And adequate training and practice is essential for accurate analysis and treatment of musculoskeletal disorders during ultrasound. Thank you.
Thank you, Dr. Sasmit. I think we will now stop the sharing. If you can stop the sharing of your screen now. Okay. So now let's move to the second paper. Guys, if you have any questions, please type in the chat box. I will request Dr. Maitri to start her screen share and put up her CV so I can introduce you. Okay, yeah, we can see your screen. Just put it full screen. Yeah, good. So, guys, let me introduce to you Dr. Maitri Shah. She's done her fellowship in pain medicine at DYPU University School of Medicine. And over to you, Dr. Maitri.
Hello, good evening. Thank you for introducing. Today we are going to do the topic ultrasound guided nerve hydrodissection for pain management, rationale, methods, current literature, and theoretical mechanism. It is taken from Journal of Pain Research 2020 by the author Skinhead Stanley Lam et al., done at multiple institutes in Hong Kong, Taiwan, and USA. Introduction. The technique of high-resolution ultrasound-guided hydrodissection of peripheral nerves has recently drawn attention to medical professionals, especially in the field of pain and musculoskeletal medicine. In this article, we review the animal model of nerve compression, injuries, and other conditions predisposing to the compression-related symptoms, historical characteristics of neuropathic pain, and theoretical benefits of decompression, how to identify the pathological nerves, methods of ultrasound-guided decompression, and available literature related to the choice of inject and efficacy of hydrodissection, due to empirical and clinical trial evidence of direct emulative effect of dextrose separate from decompression hypothesis, such should be discussed. First, what are the injuries in which we can use hydrodissection? Number one, sports injuries, sprains, strains, etc., forced nerve movements, osteophytosis, tendinosis, other degenerative changes. Areas where reduced flexibility of degenerated soft tissue is seen, post-fracture or post-surgical pain, stressed injury of nerves occurring in the process, required nerve retraction during open surgery, or scar or fibrosis tissue. The characteristics of neuropathic pain would be deep-seated pain in poor localization of source of pain. The degree of pain is usually not proportional to the degree of tissue and nerve damage. The pain can be described as soreness, numbness, electric shock in presence of hypalgia or allodynia. A sensation of cold or heat can be felt in the affected region, and the skin in the affected area may appear bluish. Similar appears in the venous stasis. This is a diagram of a nerve which shows what are these structures: epineural, perineural, and mainly the nervi nervosum, meaning the nerves which are outside the epineurum, and the vasa nervosum, the vessels, the arteries and the veins supplying the nerve, which are also outside the epineurum. Here, the nerves can be treated. There are two nerves. One is the normal nerve and one is the swollen part of the nerve, and they can be treated in different ways. First, the first figure shows a normal figure of the left common fibular nerve as seen in the cross section, which is right here, and the other structures are shown here: the fibula bone, the muscle structure, etc., followed by this where the nerve is swollen. So it is comparatively swollen as compared to the normal one, which is seen on the USG. This shows that there is an increase in the size of the nerve on the USG, stating that there has been an injury here. Going ahead, the methods. So for hydrodissection of nerve, there are two ways. Number one is in-plane approach, in which the needle is perpendicular to the long axis of the nerve. The needle and the probe both are perpendicular to the long axis of the nerve. The needle is in plane to the transducer, and the tissue above and below the nerves are hydrodissected. The needle first approaches the inferior surface of the nerve with the needle bevel positioned up, and the pressure of the inject is used to open up the soft tissues around the nerve layer by layer until the inject surrounds the epineural. The other method is out of the plane with subsequent in-plane approach. The out of the plane technique is used to hydrodissect the nerve from surrounding tissue, confirming that the nerve is free from the surrounding soft tissue by visualization of anechoic fluid surrounding the nerve, both above and below the nerve. Once this is done, subsequently, the probe is turned in plane as explained before towards the nerve. The tip is guided back to the top of the nerve and fluid is injected above it. The bevel positioned down and then approaching the nerve to make any accidental contact with the nerve. This are bevel down and bevel up position, stating the direction of the jet or the fluid of the hydrodissection. Further on, so now first understanding the clinical purpose related to the hydrodissection to method 1, specifically method 1 meaning in-plane approach. This is, as mentioned, the tool is used to separate these soft tissues. Therefore, the needle advancement is slowly done, and the needle is visualized all time during the procedure, particularly during the needle advancement. And during the advancement, the physician will continually inject the fluid. The inject incrementally separates the soft tissue in front of the needle, followed by the movement of the needle tip into the resident fluid space. As discussed, the slow needle advancement is necessary for method 1. Third, observing the bevel position, continuous needle tip observation, and continuous inject before and during the needle movement and slow needle advancement safely is further enhanced by encouraging a verbal commentary from the patient during they describe what sensations they experience during the procedure. When a nerve is hydrodissected from the surrounding tissue, there will be a common experience of aching, numbness, a burning sensation, or cramping in the distribution of nerve, particularly at the moment of facial release. And rarely an electrical sensation in the epinurum is lightly contracted when the scar is peeled off the epinurum. Method 1, the in-plane approach requires lesser inject and safely to detach the nerve from the scar tissue. The learning is rapid and not much is required for people or beginners can easily do it. Bevel position may impact the needle direction tracking, especially if a long, thin needle is used. Usually, hydrodissection of nerve is initiated from the site where the nerve is most severely damaged or trapped. If the diseased nerve or the damaged entrapped nerve is long, the same entry point can be used with the transducer and the needle pivoted to proximal portion of the nerve and after that to the distal part of the nerve, as shown in the figure. So the same entry point can be used for multiple places in the same nerve in the in-plane approach. Followed by this, the second method, which is the out-plane approach, followed by an in-plane approach. In this, the end goal of hydrodissection of nerve is confirmed by visualization of an anechoic inject above, below, and proximal and distal to the hydrodissected nerve and an alteration in the nerve shape. Either method can accomplish this, but the method 2 can separate a comparatively longer length of nerve from the surrounding tissue through single insertion point. The method 2 requires good out of plane and in plane techniques and often ability to switch back and forth between the two. If the needle tip is not visualized, the doctor keeps advancing the needle implantation of the nerve may occur. The learning process for method 2 is usually longer than method 1. This is how it is done in method 2, the outplane approach, in which the hydrodissection takes place around the nerve. Safety of ultrasound guided hydrodissection of nerve. The nerve damage is rare due to the polyvascular architecture of peripheral nerve and nerve fiber dispersal within the nerve. The importance of avoiding nerve contact cannot be overemphasized, and the advantages of hydrodissection without lidocaine may be considerable. That allows the clinician of hydrodissect continuously and liberally ahead of the needle without the concern of the anesthetic toxicity. Hydrodissection of nerve is not a technique for beginners in US guided pain intervention, especially relatively advanced skills in USG guided needle technique is required. Current literatures of hydrodissections are so combination of normal saline in carpal tunnel syndrome, outer performed a normal saline control injection. Secondly, a dextrose 5% in water with triamcinolone or a steroid, hydrodissection hyaluronidase, or hydrodissection with PRP in carpal tunnel syndrome outperforms splint only use but not hydrodissection with D5. The typical inject volume for research of hydrodissection of the median nerve in carpal tunnel is 10 ml or less. However, a much larger volume inject, typically 20 to 30 ml, needs to be completely release the nerve from the surrounding soft tissue to achieve an oval appearance, as most nerves and plexi are not located in the confined areas of carpal tunnel. The observation of the study shows 26 consecutive patients with severe pain score and neuropathic pain were treated using hydrodissection with D5 of indicated nerve root and plexi without lidocaine inclusion. At 2-month follow-up after the last treatment, the patient reported improvement in their pain and approximately of 77% improvement in the pain score. In the absence of lidocaine, multiple procedures were able to perform simultaneously if deemed necessary for more complete approach to nociceptive sources. As an observation was marked, analgesia resulted after the treatment within 15 minutes, consistent with analgesia effects of dextrose was reported. The hypothesis for direct emulative effect of dextrose on neuropathic pain is number 1, downregulation of the transient receptor potential vanilloid receptor 1 ion channel or reduction of its downstream mechanism of action, or second is correction of perineural intraneural glycopenia, which both occurs in neuropathic pain. Conclusion: Benethic animal model of neuropathic pain is most well-known and utilized animal model. Neuropathic pain results from such minimal compression that it supports the concept of minimal nerve compression is capable of creating such structural changes in nerve as well as neuropathic pain. Many conditions increase the susceptibility to sensory nerves to compression. A direct mechanical benefit from nerve release may result from restoration of nervi or vasa nervorum function through the release of pressure effects. Examination and ultrasound visualizations are jointly helpful to identify the pathological nerves. In-plane technique is recommended as primary and safer approach, with key features of inject jet to dissect the soft tissue in front of the needle and fully release the fascia until the nerve appears is rounded and the nerve is completely surrounded by the injected fluid. Limitations accepted in these studies are the small study size as just 26 and only 6 months of follow-up duration. In addition, the other clinicians that perform hydrodissection routinely may not be convinced that single injection of volume of injection listed in the clinical trial will be adequate to expect consistent clinical and electromyographic benefit in future collaborative studies. The injects evaluated other than dextrose 5% have volume limitation. Example, the steroid conjugates, hyaluronides, or PRP, making them unsuitable for multiple large volume or multiple procedure application. The critical analysis of this is the mechanical benefit of hydrodissection for benefit in neurogenic pain has not been established and will require substantial basic scientific research. Potential cost reasons: D5 may be primary inject followed by the addition of secondary inject after the initial inject has been performed, stating that the use of steroid or PRP is not very clear. Further research on current primary injects is of critical importance. And lastly, no mention or discussion of pain relief in patients beyond 6 months is noted in the study. The take-home message from this is the inject of preference may be dextrose 5% from most applications based on the preliminary literature findings, evaluating comparative injects, empirical and clinical evidences of a direct analgesic effect of dextrose separate from hydrodissection mechanism and ability of D5 to be used in high volume and multiple nerve applications. The mechanism of benefit of hydrodissection for benefit in neurogenic pain has not been established and require more substantial basic science research. Thank you.
Thank you, Dr. Maitri, for the excellent presentation. So, guys, the floor is open now for any questions. And over to you, Dr. Sanjog, if you want to discuss from any of the speakers, you can do it now.
Okay, I think so. These are very nice articles that we have included in this first journal. Regarding the first article, so here we are discussing more about how the USG can be used not only in the procedures that we are doing, but also in the diagnosis of the various pathologies that we encounter in day-to-day practice. And for newcomers who are just starting to learn ultrasound, this is the important thing, because what we are seeing everywhere is that they are going and directly trying to just learn the procedure. And we have to see this structure, this is the anatomical landmark. And so they are not actually trying to learn the basic mechanics of the ultrasound, which is the first thing that they should do before going for your applications of ultrasound in pain practice actually. So that is one thing, that is why I like this first article very much. Just one question for Sasmit.
Yes.
What do you think, where and how that ultrasound should be used by pain practitioners? Means where is the place of ultrasound in the pain practice actually? It's
So
only related.
mainly it will be mostly to consolidate your clinical examination findings. So any patient who comes to your clinic, and if you have ultrasound with you and you are having a particular diagnosis based on your clinical examination, so to strengthen the diagnosis further, to rule out certain things, I think we can go ahead with the ultrasound evaluation first. Especially like if you want to rule out some tears, or especially shoulder patient who come with supraspinatus tears or anything like that. So, or any bursa inflammation if you have bursitis. So to look out for that, to see that, I think that will be the first step for this thing. And then later on we can plan for the procedure. But the first and the most important is to come to a proper diagnosis how we treat the patient.
But what do you think? Uh, what is the learning curve, or how much importance, or how much you can say, if you are using the USG as a single modality for diagnosis and you are using it, then
Mhm.
what do you think? How should be the how a new pain practitioner should go about it, about using ultrasound?
Uh, I feel basically we have to keep doing the scans, and initial phases we can refer the patient to a radiologist first, get the scanning done from them also, and then we do it ourselves. Before we see the reports, we try to come and get one report done by ourselves, and then compare both the reports and see whether we are doing it properly or not. Or if we have some radiologist friend, we can do it
Yes.
under their guidance also. So this in the initial stages we can do this.
Yes, definitely. You should take in the initial period, you should not just blindly write the reports, or blindly uh, uh, means fully believe in your diagnosis, because definitely USG has a learning curve, and we should respect that. Secondly, sometimes if since this does not, as it was there in the article, it does not give you a bird's eye view of the pathology, just a strip kind of a thing that you can see.
Correct.
So you may miss a lot of things in ultrasound in the initial stages. So in the initial stages, definitely you should go about doing it, but you should also use other modalities like MRIs or X-rays in your initial period till you get very, very, very trained in ultrasound. But very nicely presented, Sasma.
Thank you, sir.
Any questions if are there?
No, not really. We move to the second paper.
Okay. So second article again, the nerve or dextrose hydrodissection is uh, everywhere there is discussion about this, either for the nerve hydrodissections or hydrodissection in the facial planes. So everybody is talking about this new thing. Uh, I just want to ask Maitri one question. What are the important factors, if you have read this article, what are the important factors uh, which basically decide the success of this new procedure of nerve hydrodissections? What do you think? What are the important factors?
In terms of, can you just elaborate the question a little bit more for me, please?
So, if you want to treat a nerve entrapment syndrome with this procedure, what are the important factors? Because there is not very much information there available everywhere. Somebody is doing only once, somebody is doing with only 2 ml, 5 ml, somebody is doing. So, what are the you according to this paper? What are the important factors which will help you get the better results with this new technique?
Yeah, so according to this article, number one is correct visualization of the nerve structure compared to normal. So this increase in size of the nerve has to be noted correctly, and which can be done on the USD. Of course, expertise will be required on it, but to correctly identify whether that nerve is the one which we are targeting. Number and there will be some kind of pain that is like the pain which a patient has for the first 15 minutes, but then it gets better over it. Some inflammation can be noted after the injection, which gets better a long time. So these are few things which can help us suggest that whether the nerve hydrodissection has helped or will require a repeat, or can a second inject help or not.
Okay. So just if we want to enumerate, there are 3-4 things. First is definitely the technique. So
Yes.
you have beautifully in this article they have told you there's method 1, method 2, in plane, out of plane. So you can follow these two both of these techniques for your thing. So technique is one very important thing. Second is injected. What are you injecting? So now the studies are going on for dextrose. We have already we can do with PRP, but definitely volume is a factor there. And normal, so dextrose is definitely better than normal until whatever available literature is there. And lastly is volume. So what I have read and what I have attended all the workshops and everything. So what everybody is talking about is the volume has to be more for hydrodissection. So you cannot do hydrodissection with 5 ml, 10 ml. So it has to be around 20, 25. Even for carpal tunnel, some people are doing for with 20, 25 ml. Right? So it has to be large volume, which will spread all around the nerve along a particular length of the nerve, so that it will be freed from all the adhesions that may be there. So these 3 factors are very important for success of this nerve hydrodissection. Otherwise, nice presentation. So do you want to add anything?
No, I think it's okay. Only one thing is there, if in case you have been trained on this, so then while you're doing your fellowship or your training, then it becomes very easy. Most of us, we get less of diagnostic training during our programs. Even most fellowships in the country, they are focused on difficult, and it a lot depends on the cases, number of cases also, and many things are dependent on chance. So I think when you switch into your practice, rather than becoming just an injection jockey, it will be helpful if you can utilize the knowledge of MSK ultrasound to also diagnose properly. And contrary to popular belief, with all due respect, but even a radiologist who is not specialized in ultrasound MSK will not be reporting it. So if they are so much of respect to this technique, so at least a pain physician should also give some respect to the technique. And with one area. So say, for example, I started with the knee first in my practice also, and then go on to other areas as per the your cases or your practice. Or some of us like to probably do more of clinical work. So then in clinical also you need to learn, and then probably practice on the patient. So it is already known as practice. So it's not like practice, but it is also it's actually known as practice, not without a reason. So the more you do it, the more proficient you'll become. So I think all in all, good presentations. Congratulations and thank you all of you. There are no questions unanswered, and hence I'll just switch over to the end of this session. I think we go to the last part. This is the season 4 of the Pain Journal Club, and I would just like to thank the faculties and the speakers for their contributions. And probably today we had a new time and group sessions. And of course, we have the next steps, which are there for those of you who are here for the first time. Just join a mailing list, guys. The link is already in the chat box, or if you can't find it, just mail me at mumbaiPainSchool@gmail.com, and I'll just send you that. And let's meet up next Friday, 8 p.m. Before we end, just a bit of information about our hands-on workshop, which is to be held on 9th and 10th of December at Mumbai. So those of you who want the information, just check the details in the description on social media, or just connect with me. Thank you very much. I think we end the talk for today. See you soon next Friday, same time. Bye-bye.